For patients who have progressed after imatinib and Sutent, which for most people we think is the standard second-line therapy, currently regorafenib is approved in third line, and we also have ripretinib approved in fourth line. Avapritinib was approved for D842V specific mutations in PDFR alpha. So in my practice, I have in general, because until about 3 weeks ago, I didn't have ripretinib before outside of a clinical trial setting, I have in general been doing imatinib, Sutent, regorafenib, and now it would be ripretinib. I'll talk about avapritinib in a bit in terms of where it might have a role. I think when you think about these drugs, certainly as we move forward, these drugs have been shown to have efficacy and benefit for patients. And I think one of the things that for patients with GIST we find commonly is that they oftentimes are feeling well. They are doing their daily activities. Many of them continue to work. They're not hampered by their disease. And so they are truly candidates for continuing therapy. One of the things that I tell my patients is that when I see them and their disease may be starting to grow, the important thing is to figure out what is the next right thing to do. And until then, to stay on therapy. Because we know, and it's been shown in every single one of the studies that led to the approval of Sutent, regorafenib, and ripretinib, that when you stop taking a tyrosine kinase inhibitor, even if your disease was progressing, your tumor tends to start growing quickly, and patients oftentimes have a decline in their performance status, do poorly, and can die of their disease without some form of therapy. We've seen in the trial conducted in Korea where they looked at patients who had received 2 lines of therapy. At that time, regorafenib was not available in their country, and they started Gleevec again or imatinib again versus placebo. Patients who went back on Gleevec had their disease controlled and their symptoms controlled for some period of time. So I think that's a very important take-home message. You don't want to just quit a drug cold turkey without having the next plan. If the next plan is hospice, that is a different situation. But if somebody truly is well enough to think about additional therapy, it's really important to stay on therapy, the one that's on, even if things are growing, until you know what the next best plan is. When patients are on treatment with these drugs, it is important to follow them. I think part of what I think about is where are they in their course of therapy. Certainly, imatinib is the drug where we anticipate disease being controlled for the longest. And so if I have somebody who's been on therapy for long periods of time, and I have patients who've been on the drug for 20 years, I am comfortable seeing them or imaging them every 6 months or sometimes even further. My 9 months is about my longest, so I'm not yet comfortable doing it once a year. But it's important to double check blood work. These patients can have ongoing issues with anemia and low counts because of the tyrosine kinase inhibitor. Some patients, particularly if they're taking medication for 20 years, they are getting older, and part of getting old is oftentimes seeing a change in renal function. And with a change in renal function, you may need to change their dose. And as always, we also want to ensure that there's not any issues with liver function tests, which can be a side effect from these drugs. Typically one that you see earlier rather than later, but I think it is important. So when I start a patient on a new drug, I typically will check their blood work every 2 weeks, then every 4 weeks. If they seem to be stable, then I tend to evaluate them every 3 months with their imaging, as long as they're not having any side effects. For patients who are on Sutent and regorafenib, where hand-foot syndrome can be much more of an issue, and where side effects are can be more significant in terms of having issues with mouth sores and at times difficulty with sensitivity in the mouth. I will see those patients every 6 weeks. It depends on the patient, but I do tend to watch them a little bit more closely than I might when somebody's on a stable dose of imatinib. So, and as I said, I typically will monitor patients' scans every 3 months. If I'm concerned that somebody may be starting to progress, I may take that every 2 months. But again, it's seeing your patient, how they're doing, and trying to make sure that you're managing their disease and their toxicities appropriately.